This is ABSITE and board review for the small intestine. I'm not going to get into pediatric surgery small bowel though, mainly adult surgery only. Let's start with anatomy. The three parts of the small intestine are the duodenum, jejunum, and ileum. The duodenum is easy to define anatomically as the portion from the pylorus to the ligament of Treitz. D1 is the portion from the pylorus to the start of the descending portion. D2 is the part that runs vertically downward and is retroperitoneal, and is where the ampulla of Vater is. D3 is the section that runs horizontal again under the mesenteric root. And D4 is a short segment just where the duodenum goes up and down again, where it is tethered by the ligament of Treitz. The duodenum produces hormones such as gastrin, secretin, CCK, and it absorbs iron. The jejunum is after the ligament of Treitz and is about 100 centimeters long and arbitrarily becomes the ileum, which is the last 2/3 of the length and is about 150 centimeters. The terminal ileum is specifically the last portion before the ileocecal valve and has specific physiologic functions. Absorption of nutrients and fluids largely occurs in the small intestine. BGS 123 is one way to remember that in a fasting state, the body naturally can produce 1 liter of bile, 2 liters of gastric secretions, and 3 liters of small bowel secretions. Higher amounts in the fed state due to hormonal stimulation, hence the NPO treatment of obstructive bowel disease to decrease these amounts as much as possible. So the small bowel is responsible for reabsorption of 6 to 8 liters a day of fluid, whereas the colon reabsorbs the last 1 to 2 liters per day. The proximal small bowel absorbs more fat-soluble vitamins A, D, E, and K, iron, and fats. The distal ileum absorbs more bile salts, vitamin B12, which is bound to intrinsic factor, and calcium and magnesium. The ileum can adapt better for nutrient absorption to make up for loss of duodenum or jejunum. However, the proximal small bowel cannot adapt to absorb bile salts and B12 after loss of the ileum. Glutamine amino acids is the energy source for small bowel enterocytes. Long-chain fatty acids, longer than 12 carbons, are absorbed via chylomicrons that go into the small bowel lymphatics. These go to the cisterna chyli, then onto the thoracic duct. Short and medium-chain fatty acids are absorbed directly to the portal blood. So for lymphatic leaks in the abdomen or the chest or the neck, you should put the patient on a short medium-chain fatty acid diet to prevent stimulating lymphatic flow. Loss of the terminal ileum causes diarrhea from loss of bile salt reabsorption, and you can use cholestyramine as a bile salt binder in the colon to help this. Loss of bile salt enterohepatic recirculation can also lead to fat-soluble vitamin A, D, E, and K deficiencies. Megaloblastic anemia after terminal ileal resection is due to inability to reabsorb the B12 intrinsic factor. After terminal ileal resection, patients can get oxalate renal stones. What happens is that too much fat in the colon binds calcium, so the colon absorbs more oxalate than it should, and this precipitates in the urine to form stones. Short bowel syndrome is the nutritional deficient state after massive loss of small bowel. Common clinical scenarios would be in children after necrotizing enterocolitis or intestinal malrotation, or in adults after multiple resections for Crohn's disease or ischemic disasters. Symptoms are severe diarrhea, dehydration, and malnutrition. Common numbers to hear is that if you have an intact ileocecal valve and 100 centimeters of small bowel, you should be okay. The ileocecal valve helps slow down the transit of small bowel, so without the ileocecal valve, you may need 150 centimeters of small bowel. Another estimation is that loss of more than 80% of the small bowel length can lead to short bowel syndrome. Over time, the remaining small bowel can adapt to absorb more, a process driven by enteroglucagon hormone and increased villi in the mucosa. Medical treatments of short bowel syndrome include antimotility agents such as Imodium and octreotide to decrease intestinal secretions, and PPIs to decrease gastric acid. The migrating motility complex, or MMC, is the activity of the small bowel in the fasting state and is what gives you bowel sounds, It has 3 phases. Phase 1, rest of 60 minutes. Phase 2, acceleration and gallbladder contraction, which also lasts 60 minutes. And Phase 3, maximum peristalsis, which causes the borborygmi sounds, which lasts about 10 minutes. And Phase 4, which is deceleration. The hormone motilin regulates this cycle, and erythromycin is a motilin agonist. Radiation enteritis occurs after therapeutic radiation catches the small bowel. This happens more after somebody has had surgery, then gets radiation for, say, rectal cancer or GYN cancers, etc., because the small bowel is fixed in place in the radiation field by scar tissue. Acute radiation enteritis causes diarrhea because the mucosa dies and sloughs off. Chronic radiation enteritis has the hallmark finding of microvascular ischemic changes called obliterative arteritis and strictures that can lead to obstructions. Let's talk about some structural diseases. SMA syndrome or Wilkie syndrome is when patients have rapid weight loss and the SMA and root of the mesentery have too narrow of an angle, and this squeezes shut the D3 portion of the duodenum and causes an obstruction. The surgery for this is a duodenojejunectomy, which is usually done as a loop of jejunum sewn side to side to the second portion of the duodenum through the root of the transverse mesocolon, so it is retrocolic. Duodenal diverticulum are asymptomatic 90% of the time they are present. They are most commonly near the ampulla of Vater and extend from the medial mesenteric side of the duodenum into the pancreatic head area, and they can cause biliary obstruction and pancreatitis. The treatment for biliary obstruction problems should initially be trying to avoid surgery. Try maybe an ERCP and a sphincterotomy of the ampulla with a stent. If you are forced to operate for bleeding or refractory obstructions or perforation, be sure to cannulate the ampulla and pay attention to it since it will be nearby. Blind loop syndrome can occur after anything that leaves a segment of small bowel with stasis, such as a surgical rerouting or a big diverticulum. The overgrowth of bacteria can cause pain, diarrhea, and megaloblastic anemia from B12 deficiency due to bacteria using the B12 up. Treat blind loop syndrome with antibiotics and B12 supplements. Crohn's disease. Crohn's disease can affect the intestinal tract from the mouth to the anus, but it can be discussed in the small bowel lecture because it commonly affects the ileum. The ileum is actually the most commonly affected site in Crohn's disease, being involved in 75% of patients at some point. Both the ileum and the colon are involved in 40 to 60% of patients. The ileum only is involved in 30%, and the colon is involved alone in 20 to 30%. Infectious causes of terminal ileitis include Yersinia, CMV in immunosuppressed patients, Salmonella, Campylobacter, and Shigella, so rule these out with stool cultures before assuming isolated Crohn's disease. The important findings in Crohn's disease are transmural inflammation, non-caseating granulomas, creeping mesenteric fat, skip lesions, and mucosal ulcerations, which can lead to cobblestoning of the mucosa. Common symptoms are diarrhea, abdominal pain, and weight loss. Bloody diarrhea is actually more common with ulcerative colitis, though. Perianal disease is common in Crohn's, and the rectum is usually spared, as compared to ulcerative colitis, which is the opposite. Ulcerative colitis has no perianal disease, and the rectum is almost always involved. And ulcerative colitis doesn't involve the small intestine, so let's stop talking about it here. Extraintestinal manifestations of Crohn's include arthritis, ankylosing spondylitis, iritis, erythema nodosum, and pyoderma gangrenosum. The transmural inflammation can lead to fistulas. Chronic inflammation can cause strictures also. Initially, try medical therapy for strictures with NPO, TPN, and steroids. Surgical treatment of a single area of stricture could be a simple resection, but if a patient has multiple strictures or multiple surgeries, you should try stricturoplasty instead of resection to help preserve length and prevent short bowel syndrome. The Heineke Mucolitz stricturoplasty is when you cut longitudinally and suture transversely and is used for short segment strictures. you should use the Finney technique for long segment strictures. Crohn's disease is associated with an increase in small bowel and colon cancer. Medical treatment of Crohn's is divided into drugs for acute flares and those for maintenance therapy. Treatment of Crohn's flares is with steroids. Steroids should be weaned or stopped if able after the flare cools off. Aminosalicylates like sulfasalazine or mesalamine can help by decreasing inflammation and are used for maintenance. Azathioprine is often used as an immunosuppressant and is used more for long-term maintenance in Crohn's patients. Infliximab or Remicade is a monoclonal antibody against tumor necrosis factor and is used for steroid refractory flares and specifically to help close Crohn's fistulas. After proctocolectomy for Crohn's, remember not to do an ileoanal anastomosis or an ileal J-pouch procedure, since the ileum is usually involved and this won't heal well. That surgery is used for ulcerative colitis or FAP or HNPCC, etc. And ileostomy is the safest thing to do for Crohn's patients that require a total proctocolectomy. Small bowel fistulas are kept open by things remembered by the mnemonic FRIENDS: foreign body, radiation, infection, and inflammation, such as Crohn's, epithelialization of the tract, neoplasm, distal obstruction, and steroids. Small bowel obstruction is a common thing for surgeons to treat. The most common causes in adults are adhesions, followed by hernias, and then tumors. The normal small bowel diameter is about 2.5 to 3 centimeters. So in a small bowel obstruction, the KUB will show dilated small bowel, air fluid levels, and you can tell that it's small bowel due to the valvulae conniventes. These are circumferential lines that run across the entire small bowel as compared to haustra in the colon that are only partially across the lumen. The term closed loop means there is no way for fluid to decompress out of either end of an obstructed segment of bowel. This could be due to a loop of bowel twisted on its axis causing the closed loop. Closed loop obstructions lead to ischemia of the bowel quickly due to both vascular congestion and strangulation due to the twisting of vessels, and also the continued distension of the bowel wall due to third spacing of fluid into the lumen. Never let the sun set or rise on a closed loop obstruction, meaning these are not the ones to place an NG tube in and wait for it to resolve on its own. Now granted, the vast majority of small bowel obstructions are open-ended due to a specific point of obstruction in the small bowel. This can lead to fluid backing up throughout the small bowel all the way to the stomach. This is not considered a closed loop. These are the ones that should be treated initially with NG tube, IV fluids, watch for good urine output, and correct the electrolytes. Roughly 60% of small bowel obstructions will resolve on their own with conservative measures. Deciding what small bowel obstruction needs surgery is somewhat of the art. Some pearls and basic rules should be as follows. Failure of non-operative therapy to resolve the small bowel obstruction by 72 hours, one should consider surgery. Feculent output from the NG tube or in the emesis is a bad sign. This means that the small bowel contents are so stagnant that they are turning into something that looks like stool, and this is a good sign that the obstruction is unlikely to resolve on its own. Fecalization of small bowel contents just above the obstruction on CT is a similar finding. Obviously, anybody with a high lactate, acidosis, sepsis, leukocytosis, or peritoneal signs needs a surgery right away. Patients with previous Roux-Y gastric bypass with small bowel obstruction should be considered for early laparoscopic evaluation to rule out internal hernias through Peterson's space or mesenteric defects at the jejunojejunostomy. On a board exam and early in your career, you should have a low threshold to operate on small bowel obstructions. Briefly, let's discuss postoperative paralytic ileus. The KUB shows diffuse and uniformly dilated small bowel without air fluid levels, which is consistent with ileus. Routine NG tube does not help. Reducing opioids might help. Maybe try Toradol or ketorolac, but prolonged high doses with recent bowel anastomoses has been linked to increased anastomotic leaks. Gum chewing has been shown to help in studies. Levomapan or Entereg is a mu-opioid receptor antagonist the FDA has approved for postoperative ileus. Certain syndromes that involve the small bowel can show up on the tests. Peutz-Jeghers has perioral discoloration and multiple hamartomas of the distal small bowel and can increase the risk of breast cancer. FAP has multiple colon polyps and also gastric and duodenal polyps that need screening for progression to cancer. FAP with bone osteomas is known as Gardner's syndrome, and FAP with brain tumors is known as Turcot syndrome. After FAP surgery, patients can develop desmoid tumors in the small bowel mesentery, usually near the root of the mesentery. Often these desmoids are not operated on and are treated medically with Solindac or estrogen blockers. Osler-Weber-Rendu syndrome causes hemangiomas throughout the GI tract. Less than 5% of all GI tract cancer is in the small bowel. Probably this is due to the rapid transit of material through it. If an older person develops small bowel obstruction without previous abdominal surgery or hernias, think about a tumor. The main ones to know about are adenocarcinoma, carcinoids, GI stromal tumors, and lymphoma. Adenocarcinoma is usually in the proximal small bowel, such as the duodenum. Duodenal adenocarcinoma is usually treated with a Whipple surgery. Occasionally, if you can catch it early as a periampullary villus adenoma, you can just remove the villus polyp by doing a transduodenal periampullary resection and reconnecting the distal common bile duct to the remaining duodenal mucosa. Jejunal to mid-ileal adenocarcinoma needs resection with 6-inch margins on either side. Distal ileal adenocarcinoma is more common in Crohn's disease, and terminal ileal adenocarcinoma needs a right hemicolectomy. Carcinoid tumors of the small intestine are known as midgut carcinoids. Small bowel carcinoids can be very small, yet generate large lymph node metastatic lesions in the mesentery and liver metastasis also. 40% are in multiple locations, so be sure to run the entire small bowel when operating on these. Carcinoid syndrome, characterized by flushing, diarrhea, bronchospasm, and right heart valve disease, tends to occur after liver metastatic lesions have developed, since most of the serotonin is metabolized by the liver. Carcinoid syndrome can cause pellagra, which is dermatitis, diarrhea, and dementia, due to low tryptophan being diverted to serotonin production and away from niacin production. The best test for carcinoid is the urinary 5-HIAA level, which is a breakdown product of serotonin, and serum chromogranin A. The best imaging test is now a PET dotatate scan, which has replaced the octreotide scan. You should explore to remove the primary small bowel carcinoid since it can continue to shower metastatic disease. Debulk as much liver disease as possible even if residual bulk tumor or an R2 resection is done, since even this shows survival benefit. Remove the gallbladder prophylactically since octreotide can cause gallstones. Octreotide treatment can be used to slow tumor growth and help with symptoms. GIST tumors are from the interstitial cells of Cajal. They are CD117 and DOG1 positive on immunostains, and most of these contain the c-KIT mutation, against which Gleevec or imatinib is targeted. Remove GIST tumors of the small bowel to prevent bleeding, obstruction, and intussusceptions. No lymphadenectomy is needed. Remember that gastric GIST is the most common location though. GIST is classified as higher risk for malignant behavior when it is over 5 centimeters in size and greater than 5 mitoses per high-powered field. The small bowel GISTs tend to be more aggressive than gastric. Small bowel lymphoma is more common in the distal small bowel, since there is more lymphatic tissue in the form of Peyer's patches in this area. T-cell lymphoma is associated with celiac sprue. Non-Hodgkin's B-cell lymphomas are the most common small bowel lymphomas though. If the lymphoma is only in a segment of bowel and not in lymph nodes or other sites, then it is considered stage 1 and could be treated with surgical resection and maybe post-operative radiation. If the small bowel is part of multiple areas of lymphoma, however, these are treated with chemotherapy, but you would need surgery if it caused bleeding, perforation, or obstruction. If resection is needed, you don't need to resect to microscopically negative margins, just to grossly negative margins. The other time you may be asked to do a small bowel resection for lymphoma is if a segment of small bowel is mostly entirely replaced with tumor. Sometimes the chemotherapy will actually melt the tumor so fast that the bowel will perforate. So sometimes medical oncology will ask for prophylactic small bowel resections. The most common metastatic disease to the small bowel is melanoma. These are classically associated with GI bleeds and intussusception lead points. Resect the small bowel intussusception in adults since it usually has a lead point, so it's either malignant or will recur. The intussusceptum has a septum and it goes into the intussusceptions. Don't pull it to reduce, push it from the intussusception's end. Small bowel acute mesenteric ischemia is good to know about. The blood supply to the small bowel is the SMA artery. Clinical and radiographic findings of acute mesenteric ischemia includes sudden onset of pain out of proportion to abdominal exam, guaiac-positive stools. Labs will show elevated lactate, leukocytosis with a left shift, and acidosis with hyperkalemia if the bowel is dead and cells are leaking. Radiographs show distended paralytic ileus, edematous small bowel wall that can have thumbprinting, and an advanced ischemia and pneumatosis of the bowel wall with portal venous air. Remember that portal venous air goes all the way to the periphery of the liver, whereas air in the bile duct stays central in the liver. CT angiogram is probably the easiest way to see the location of the SMA disease, although most still say a formal angiogram is the gold standard. The 4 types of small bowel ischemic disease are embolic, thrombotic, NOMI, and mesenteric venous thrombosis. Embolic disease comes from clots, usually from the heart. These tend to lodge distal to the first jejunal branches, so there is relative sparing of the first few feet of the jejunum, but the rest of the small bowel and right colon can look ischemic. These are treated with surgical embolectomy via transverse incision on the proximal SMA and pulling out the clot with a Fogarty balloon, then closing the arteriotomy. Thrombotic SMA disease is from gradual narrowing of the root of the SMA. Classic symptoms include food fear and intestinal angina after eating, since the increased demand for blood flow causes relative intestinal ischemia, leading to weight loss. Normally, the small bowel gets about 10% of the cardiac output at rest, but this can increase up to 50% of the cardiac output during digestion, and 75% of the blood flow goes to the mucosa and submucosa, which is why these show ischemia first. Usually it takes stenosis of both the SMA and the celiac to cause problems since there is some collateral flow. If somebody develops acute on chronic occlusion of the SMA, then the entire small bowel from the jejunum through the right colon can be involved, and a vascular surgeon needs to do a bypass to the distal SMA. NOMI, or non-occlusive mesenteric ischemia, refers to patients that have this when they're on pressor medications. Usually they're critically ill. The classic findings are intermittent vascular spasms, which can look like a sausage-like pattern on an arteriogram. Try not to feed the gut too much if a patient is on pressors. Treatment is using intra-arterial vasodilators like papaverine and aggressive fluid resuscitation, and obviously trying to minimize pressor use. Acute mesenteric venous thrombosis of the SMV or the portal vein can lead to venous hypertension and edema of the bowel wall, leading to poor blood flow. Treat this with TPA, if possible, and anticoagulation. The other things to know about acute mesenteric ischemia is to determine bowel blood flow. You can Doppler the mesentery, or you can just look at how pink the bowel is, or does it still have peristalsis? Maybe you can use IV fluorescein and a Woods lamp, or the newer indocyanine green techniques, but this needs a special camera. Another pearl is to resect grossly abnormal bowel and leave it in discontinuity, and do a temporary abdominal packing and bring the patient back 24 to 48 hours later to see what bowel has survived and then try the reanastomosis. I am a big proponent of this technique. The last thing you want to do is to do a reanastomosis of bowel that is going to become ischemic. All right, that's all I got. I hope that helps. Good luck.